Welcome back everyone again to the Research Weeks podcast here at the pre-conference workshop at Meldron, EACD and the IAACD 2025. And we have changed location for a very special guest, Liz Boyer, clinical scientist at Gillette's. Thank you so much for being here.
Thank you for inviting me.
Amazing place. We're currently in the monastery itself, which is the centre of the town. And it's pretty incredible to be here amongst all the history and to have the opportunity to talk about new research and new science. What a way to do it.
Agreed.
Tell us a little bit about your background, Liz. What brought you to this conference and kind of the work that inspires you?
Yeah, this is my first EACD conference and actually my first time in Europe.
Oh,
so
wow.
A lot of firsts for me.
That's wonderful. What an experience.
Yes. I've been to the AACPDM, American Academy of Cerebral Palsy and Developmental Medicine Conference many years.
Yes.
So this was a great opportunity to branch out and meet more people and just present some of our work in pain and falls in a new space.
Yeah, well, I have to admit, when I looked at the work that you're presenting, it really caught my eye because these are two themes and topics that are so real for the families that we work with. So I want to make sure we've got enough time to talk about both. Partly out of my own selfish needs, but I know that these are things that we talk about and think about all the time. So let's start with talking about pain.
Okay.
Increasingly, we're recognising pain is so prevalent in the children that we work with. Tell me a little bit more about the work that you've been doing in pain and the specific focus.
Yes, I started getting involved with pain research in adults with CP since I started at Gillette 10 years ago.
Okay.
We did a long-term outcome study looking at a specific orthopedic procedure.
Okay.
And we brought young adults back and asked how they were doing, 8 to 15 years after surgery.
Okay.
So we started that comprehensive assessment of outcomes back then.
Wow.
And then from there, my curiosity just grew and I started partnering more with Chantel Burkett, another clinical scientist at Gillette, and she's one of the foremost researchers in pain, particularly nonverbal pain in people with cerebral palsy and other developmental conditions. So we did a publication a few years back looking at pain after orthopedic surgery because it is uncommonly measured.
Yeah.
And then that grew into some prospective work that is still ongoing.
Oh, fantastic. I'd love to touch a bit on the findings of the study that was published, but a bit more background on pain and surgical-based outcomes. I suppose it's almost like it's a given that there will be pain following surgery. But what is it that's usually articulated to families as they prepare for a surgical procedure, especially for children who are nonverbal, who do have pretty big surgeries? Yeah.
I think it depends on the surgery that's planned, what is communicated about possible pain in the short term and then during recovery.
Yeah.
As a non-clinician myself, I don't always know what those conversations are, but I think more and more it's being recognized and addressed up front. And again, not just that short-term, expected pain during recovery, but also start anticipating what this surgery might have effects on pain in the long term, whether it's a year or 10 years out, because oftentimes those surgeries are done prophylactically to prevent long-term pain or joint degradation and harm. So I think there's raising awareness, but there's still a lot of room left to improve.
And so what did your paper find, and I suppose how does that direct in some of your future work that you're currently undergoing now?
Yes, so we did those long-term outcome studies, and we didn't find too much of a difference between a particular surgery and maybe no surgery or other surgery in long-term pain. But we also did a shorter-term study a few years ago where we looked at prior records based on our gait analysis lab data. So everyone came through there, and we had 86 children, and we grouped them into 4 groups, whether they did or did not have pain pre-op and post-op. And it was really interesting because the group that had pain pre-op and about 1 year later when they returned to the gait lab yet.
Yeah.
If they had hip and knee pain, they were more likely to report a decrease in physical function.
Right.
And so that was very different than those other 3 groups who either did or didn't have pain. And so that was really motivating for us to say, I think there's something here, right? If we can't manage the pain and it continues to be a chronic problem, that really is probably preventing them to have better improvements in their mobility and their participation in sports and other function, because that was our primary outcome.
Absolutely, and you can see how that would have such a flow-on effect in terms of planning and support and equipment and modifications they might need in different settings. So where are you up to with that now? What's the current work that I'm sure we'll speak about in a few years' time?
Yes, we used that as some preliminary data for a big NIH grant.
Congratulations
and we
on getting
thank
that.
you.
It's not easy to get.
Yeah. Prior to that, we started kind of a smaller internal proof of concept prospective study, and we expanded that when we got the funding to enroll hundreds of people. So we're up 177 participants across our site and more children in Delaware. Yeah, and so we really are trying to track that progression of pain from before to up to 12 months after surgery, and look at opioid use and other impacts on gait and so forth. So we're really excited that it's really the first really big prospective pain study after orthopedic surgery in children with cerebral palsy. And I'm most proud of our enrollment of individuals across all and severity of gross motor ability.
Wow.
So we aren't just looking at ambulatory individuals.
That's fantastic. There's such a dearth, isn't
there?
Yeah. Yet so many children do undergo orthopedic surgery. So when, the big question is, when do you think data collection will come to an end for that? What's your timeline?
2027 is when we'll finish our enrollment. And so we hope to be over 200 individuals and have almost that many, near the 12-month time point at that.
That's the joy of a follow-up study, isn't it? You've got them, but then there's still the extra time. But this is really crucial for us moving forward as a field to better support these families. Okay, well, we'll look forward to that.
Thanks.
The other area that I'm really interested in when I saw the work that you'll be presenting is about falls. And I would say, whilst I see this happen clinically a lot every day, and it's reported a lot every day, you're the first person I've spoken to with regards to doing any work in the area. Tell me a little bit about what brought you into the space to look at falls.
I started as a postdoc at Gillette in the gait lab, and we heard from so many patients that their goal or major concerns are frequent tripping and falling. And I was just surprised also about the lack of research in the area. There was a little bit more published, primarily in the adults, with CP back in 2013, 2015. There's a few papers published there, but then it kind of dropped off.
Was that for cerebral palsy, or?
Yeah, it was.
Okay. Wow.
Yeah, and I wanted to revive that because it seems like it was such a prevalent concern. And then as I started talking more to young adults and middle-aged adults with CP as well, they mentioned how falls are such a big concern. The falling down part, the standing back up part is, I learned also was a real major concern, particularly for individuals as they get older, or those who are GMLCS level 2 or 3, who need that extra level of assistance to help them stand up. And there was just this unmet need, and I wanted to gather objective data to put behind this to say this is a problem. And as we'll probably get into, not just physically, like the injuries, but also psychologically.
Absolutely. That part is such a significant component, and that's what you hear when as they get older, as children get older, you hear them that language, that self-talk almost. Back to, I guess, trying to collect some objective data. Do we have numbers on prevalence of falls? Is there anything published along those lines?
So I recently published a paper, and it was kind of our quantitative component. We enrolled, I sent invites to all patients at Gillette, children and adults. And then in the United States, we also have a cerebral palsy research network, CPRN, and that's across multiple sites. And I worked with them to recruit more adults as well to answer these surveys. And we broke it down by GMS, and this was ambulatory individuals only, partially because we believe the mechanism of falls are different for non-ambulatory and ambulatory. But the prevalence of falls, so the percentage of individuals reporting a fall in the past year, ranges from about 70% in GMSCS level 1 to over 90% in GMSCS level 2 and 3. So
That's very high.
Pretty much everyone falls. And this is based on retrospective recall, right? How often you fell. My big goal is to do a prospective study similar to the pain study,
I can imagine,
and try to capture a little bit more accurately. But so we reported levels that high, you know, maybe 70 to 90% or so. There's a few other studies, much smaller, in adults with CP who've reported about that same rate, sometimes lower, but almost all are estimating over 50% of individuals fall.
Either way, it's a very high prevalence,
Very
isn't it?
high. And so many of those individuals fall more than once in the past year. So they're multiple fallers.
And are they factors like age, or is hemiplegia unilateral versus bilateral that come into this?
Yeah, that's one of the presentations I'll be covering this weekend. Or this week. And it does seem that individuals who have bilateral involvement of both legs do fall more often and more frequently than individuals who are just involved unilaterally. So that does seem to be one of the predictive factors. Age, in that big study of over 300 individuals who participated, individuals younger, so less than 12, do fall quite often, the most, and then it kind of decreases, and then it slightly increases. And we didn't have enough people at the, you know, older adult age, typically 65 or older, to really give solid estimates for that age group. But it does seem like it's very high in childhood, decreases, and then maybe slightly increases later in life.
Why do you think that is? Do you have any guesses? I'm sure you've all postulated a bit.
Yes, always. I think partially it is experience and maturation and strengthening and everything during childhood. Because they generally acquire some of those walking skills later, then I think you have some of that maturation naturally, right? That occurs a little bit later. I think part of it too could be, you know, changes in self-restriction, or how daring children are, or even how many steps they get in per day.
That's right. That was an interesting thought. I thought, that's also the time where they tend to move less.
Yes.
And do they move less? Why do they move less? You know, is it because they know they've got a higher prevalence of falls, and does that tie in with the social aspect of falling because you're now at high school?
It could be multifactorial and different for everyone.
Interesting to think about.
It was, it was very true. When we did that survey, we had kind of open-ended questions too. And one of the participants, I believe, was an adult, but they said they must have recently started becoming more physically active for their health. And they said, I fall more now because I move more.
Wow.
And so, you know, it just made me also reflect that we can't only look at number of falls without considering those extra conceptual factors, right? Like you're still improving your health because you're moving more. Maybe you're falling more too, though. So like, you know, you almost need to normalize how many times they fall compared to how many steps they take. I don't know. So lots of things.
There's a lot of things to think about. And I guess it's because it's such an early part of the research, really. There's a lot to tease out. What about when it comes to injuries of falls? You know, because we can fall and we can scrape our skin, we can have bruises. Has there been anything more seriously reported in terms of falls?
Yes, there has been from our study and those few other adult studies as well. Whether it's fractures or concussions or joint dislocations were not that common, but sprains were very common. Oftentimes, you know, I have quotes again from our participants saying, I nearly always get some type of bruise or bump or cut when they fall. And
Yeah.
so those, while they may bother them a little bit, it seems like many of them are very resilient
Yeah.
and brush that off.
Yeah.
But injuries, particularly the more serious ones,
Yeah.
really become a greater concern
Yeah.
as people enter that kind of middle adulthood and late
Sure.
adulthood,
Yeah.
where they really are worried more about those fractures that are
Yeah.
going to cause an inpatient hospital stay or
Sure.
really prevent. A lot of them is really, again, I learned so much from this
Yeah,
research. I
it
really
sounds
love
like
it.
it. It's amazing.
And they speak to their inability to participate and do their normal social roles, right? So if they have a spouse and they can't be as helpful around the home,
Right.
or a lot of them bear the burden of worrying about being able to continue to work outside of the home or feeling a burden to their employer too,
Wow. Okay.
and everything else if they suffer a fall there.
A lot of layers to that,
Yes,
isn't
there
there?
is,
There
yeah.
really is. And when we're trying to promote opportunities and for employment, and when we talk about participation, not just attending but being involved, falls is a big part of that.
It is. Yeah.
Can we talk a little bit more about the psychosocial elements of it? Because I think that's an area I can see that lights you up, and it's something that I see a lot, and I can feel a lot as our kids get older, and they falls are met with either just extreme embarrassment, and they get back up again,
Yeah.
or it's something that prevents them from wanting to try again. But there's some
Yeah.
kids who do bounce back as well. You've
Yeah.
got the full range.
Yes. Yeah.
What are your thoughts on that from some of the data that you've seen?
Yeah, in our big study, we measured concern about falling.
Yeah.
Sometimes even the word fear of falling.
Okay.
As I was planning and working with some adults with CP and planning that study, they didn't always like that connotation.
Right.
So concern about falling is almost more appropriate.
Okay.
And doesn't always trigger
That's
that
good to know.
kind of
Yeah.
defensive response or claiming that there's a fear, but it's more
Sure.
concern.
Oh, that's fair.
So
Yeah,
we
okay.
used a survey, the short FESI, so function. Gosh,
We can put
drawing
that in
a
the
blank.
comments.
Yeah.
I know, because we do acronyms all the time, don't we? Once a year, we want
Yes.
to unravel them.
False
all.
Efficacy Scale International.
Nice
Thank you.
one.
But we use that measure, and it has
Okay.
kind of a partner measure called the FESI-AD, activity avoidance.
Okay.
So patients rate their response on that as well. And then I used one other one.
Right.
And so there was some, and kind of more than, for instance, older adults,
Sure.
who report activity avoidance due to their concern about falling. So that
Right.
was surprising.
Yep.
And we had other scales kind of measuring embarrassment and other factors like that. And they were also quite high. I was expecting to see, and granted, I grouped some of the younger age groups together, but across all age ranges, it was pretty high. So it's not like we saw a huge spike,
Okay.
even though I feel like we hear that. But I wonder if, because I grouped 5 to 12-year-olds all together, if I would have
Sure.
broken that down more, maybe there would have been a greater increase with that younger age.
Okay.
But yeah, it was pretty much high across the
Wow.
lifespan. And
Just
so
concerning already,
yes,
anyway.
it's concerning, right?
Right.
Yeah.
Yeah.
So I just think that we need to consider that aspect of it, because like
do.
you said, some individuals, it prevents them from engaging more.
Yeah.
And I have some really great quotes on that that hopefully will be coming out in publication soon.
Beautiful. Okay.
Yeah, I think that was kind of the most stark finding.
Yeah.
Was they are like several of the individuals reported that they were less concerned about the physical effects of a fall and more about those psycho-emotional
Yeah.
ramifications from the falls.
Yeah. And you can relate to that.
Absolutely.
I think if I trip and fall, and as an adult you trip and fall, you look to see whether you've actually tripped over something, and you realize you actually haven't, and how you face people around you or how you explain it. And I imagine from a lot of other research for individuals with cerebral palsy, they don't want to keep explaining that they have cerebral palsy and given that reason. So I imagine that comes up a lot too. It's a really interesting area of research, Liz, and I can't wait to see this all being published. But thank you for sharing your absolute passion with it, which I think is going to make a significant impact on so many people. And yeah, we'll talk again soon.
I would
feel
love
like
that.
we should do that.
Yeah,
Yeah,
I would
yeah.
love that.
That'd be great. And on the outcome measure as well, the FESI, wasn't
Yeah.
it? Yes. Is that something that we could be doing in our practice as part of an interview? Is that something we should incorporate? Or is it more, yeah, what's the nature of that outcome?
I think typically it's used more in research,
Okay.
but I chose the short version, which was
Okay.
7 items.
Okay.
And I think it's short enough if we wanted to use
Yeah.
it, we could.
Okay.
In talking with, I have adults or parents of children with CP who are co-authors on those projects with me.
Okay.
And they want to talk to their providers about falls.
Sure.
They don't love answering surveys, a whole bunch of surveys.
True. That's true.
So-
yeah, let's not pop another one for them. Okay,
yeah,
fair enough.
Yeah, so
but we should acknowledge it in our interviews and discussion points.
Yes, especially if
Yeah.
it's a safe space.
Absolutely, yeah.
Where you know, they genuinely care and want to help.
And be thoughtful about our language,
Yeah,
like you said. Fear of falling versus concern. That was a really good point.
Yes,
yeah.
yeah.
Thank you. Thank you so very much for that. And enjoy the rest of the conference and your time in Europe.
Yes, I will. Thank you.
Wonderful. Thank you so much for joining us, everyone. That was such a great talk. And I think it's something that we all need to be very thoughtful about. Once again, it's another barrier, but it's something that really impacts a lot of the kids we work with. But we don't know unless we ask them. So yeah, that was a great reminder, Liz. So stay tuned for so much more, but we'll talk to you all again very soon. Bye.